Okay, good morning, everybody. My name is Jackie Cannon from the Lewy Body Society, and thank you for joining our webinar this morning on the very important subject of hallucinations. We're very privileged to welcome with us this morning two experts on that subject, Professor John Paul Taylor from Newcastle University, and Rachel Thompson, who is a consultant Admiral Nurse working from Dementia UK and funded by the Lewy Body Society. So I'd just like to give them the opportunity to introduce themselves before we go into our session. So John Paul.
Yeah, thanks very much for that introduction. So my name is John Paul Taylor. I'm an old age psychiatrist and a doctor based in Newcastle. I've got a specialist interest in Lewy body dementia and see people clinically in that fashion. I also do a lot of research into the field of Lewy body dementia, and visual hallucinations is one of the areas that I look at and trying to, I suppose, understand the causes of visual hallucinations and how to treat them better.
Thank you, John Paul. Rachel?
Hi, thanks, Jackie. I'm Rachel Thompson. I'm currently working as a consultant Admiral Nurse. I've worked in dementia care, gosh, for over 20 years now, and been a nurse for a lot longer than that. But I have worked with supporting families who are affected by dementia in my role as an Admiral Nurse. And over the last nearly 2 years now, I've been working with the Lewy Body Society, just specialising in the particular difficulties that families who are affected by Lewy body dementia are faced with. And I'm delighted we're doing this topic today, because I have to say I still get lots of queries. Lots of families really struggle with hallucinations, and so hopefully we can try and unpick and have some conversations about some of the things that we think from our experience might help people. So thank you.
Thank you, Rachel. So we'll go straight into this very important topic. John Paul, can you tell us about visual hallucinations in dementia with Lewy bodies, and are they common?
Yeah, so they are common. I mean, again, it depends on what populations we're looking at, but probably as a rough estimate, about 3/4 of people who have got Lewy body dementia will experience complex visual hallucinations. And what we mean by that is essentially seeing things which are not there. That's the essence of hallucinations. And often what people will see is often what we call of a biological theme. So that means seeing animals, children, people, typically. And, you know, again, a very sort of common story, and I'm sure Rachel sort of also described this, is this perhaps, you know, you might hear of mum leaving food out on the table for visiting children, or food out for cats which are coming into the house. And you know, these can be really sort of very vivid experiences for people, and they're, you know, they often can be associated as well with other symptoms such as the delusion. So that's sort of fixed beliefs that people have, which aren't necessarily true. So they might believe that there's an intruder in the house. They might get anxious. They might get agitated. They might get distressed. A lot of other people get some degree of comfort from these sort of experiences. For example, seeing, you know, a dead relative, you know, present, it makes them feel, you know, a little more reassured. And sometimes actually the challenge is not so much for the person living with Lewy body dementia, but actually for the family members having to deal with it. And I think that, you know, again, what we tend to see is that a lot of the hallucinations aren't of the what I would call fantastical theme. They're not of, like, you know, I suppose giants and dragons and weird and wonderful things. They're often quite sort of, I suppose, boring in a day-to-day way. You know, you might have, you know, the cat sitting on the sofa. You might have, you know, spiders coming down the wall. You know, nothing dramatic. It often fits within the normal day-to-day life of people, that they sort of experience these things. So that's why, in a way, it's sometimes going to be challenging for people to say, is this real or is this not real? Because it's actually quite normal, as it were. And I think, again, you know, these phenomena can vary from person to person. Sometimes some people will get very minimal, maybe very occasionally, then they might experience them, and then others will be experiencing them virtually all of the time. Some people will get them more at certain points of the day, for example, in the evening time or nighttime, or perhaps only in one setting. I mean, typically people, again, might experience them more in the home than out and about, because often the hallucinations come in the more, I suppose, familiar settings that people experience. And again, what the sort of range is, I've talked about the sort of complex visual hallucinations, but some people will experience some sort of intermediate or subtle symptoms, and these can sometimes actually happen before the hallucinations appear. And these are things such as illusions or pareidolias. Now, we've all experienced pareidolias. That's when, you know, we look up at the clouds and we might sort of see a face in the clouds. And people with Lewy body dementia might have more vivid pareidolias. So they might look at a bush or a patterned wallpaper and then say, oh, I can see a face there, which is coming out. And so that's not quite the same as a fully formed hallucination, which is sort of pops into existence. And so there's a sort of a broader, not just the visual hallucinations, but there's a sort of a broader range of visual experiences that people can have, which are sometimes in themselves quite troublesome and difficult to manage. And then I suppose the final point I'd just like to say is that we're talking about complex visual hallucinations here, but we know that some people with Lewy body dementia also experience hallucinations in other sensory domains. So, for example, hearing voices or sounds, feeling something touching their skin, smelling something, tasting something. And sometimes these can go with the hallucination. So you can really build up the visual hallucination. So you can really build up this, I suppose, world of strange experiences. And you know, the final, I suppose, point I would want to make is that, you know, insight, this is sort of knowing that whether it's real or not real can vary from person to person, from time to time. So that does make the overall phenomena and the symptom quite hard to manage sometimes. So I think hopefully that's a sort of a rough overview of complex visual hallucinations in Lewy body dementia.
Thank you, John Paul. And I should have said, if participants for today's webinar, if you have any questions for our panelists, if you could put them in the Q&A box, and we will try to answer as many as possible at the end. Rachel, what impact does visual hallucinations have on people with DLB and their families?
Gosh, that's a really important question, Jackie. So I think my first answer is it varies from person to person, from family to family. So for some people, as John Paul was saying, actually, if the hallucination feels kind of fairly normal, it might be that the impact isn't huge. So it might be, as you say, if somebody's seeing something that offers them some comfort, then it might be actually the person who's experiencing these might not even say something to their family member. And often one of the things that we say on assessment is, and I've heard families say, when, you know, a nurse or a doctor's asked them a question along the lines of, do you ever see things that you're not sure if they're real or not? Or do you think your eyes play tricks on you? People will admit to seeing things, and their family member, perhaps even a spouse or husband or wife who lives with them, may not even be aware that was happening. So I guess that's the first important thing, is how much, what kind of impact is it having on somebody, and finding out, is it something that is persistent? Is it something that just happens kind of occasionally? And how distressing is it? Sometimes, as John Paul was saying, is these hallucinations may not be that upsetting or distressing, but may start over time start interfering with what that person's able to do. So families may say things like the person's perhaps not eating so much. So I've worked with families where somebody's been leaving food out for children who were being seen and then weren't eating themselves because the food wasn't being eaten, so they were so preoccupied. Or it might be somebody stops going outside because they're seeing somebody outside and it's becoming a little bit frightening. Perhaps they feel that they're starting to be watched. It might be that if there's hallucinations appearing in a specific room, for example, the person may stop going into that room. So if that's starting to happen, then of course, as a family member, or, you know, your person yourself, is that it's starting to impact on the way that you live your life. There are some hallucinations that can be very frightening and very distressing, and these are particularly difficult, I think. And maybe that if that person is stopping doing something as a result, or starting to accuse other people of perhaps, you know, going behind the back, or not believing them, that can be a real source of conflict and distress. So I think the impact really does vary. I think we'll go on to talk about some practical steps, but I think the first thing is trying to think as either person yourself or with the condition or a family member, how fixed is it? Does that person have enough insight to be able to have a conversation about, oh, do you think this is real or not? And then that's a good starting point to work out, well, how do you respond and how much help do you need? I think John Paul is going to go on to talk about treatments, so I'll leave him to talk about that. But I think if anybody's noticing any odd behaviour, somebody's acting a bit suspiciously, or you're worried yourself that you're seeing things you're not convinced they are real or not, then my recommendation is always just seek advice, talk to somebody, because people often don't admit it because, you know, you might kind of feel a bit silly, you know, am I seeing, you know, what's going on? So giving people the space and the opportunity to say, I'm a little bit worried about this, is just a really important starting point. I think that's probably it.
Thank you, Rachel. John Paul, do we know what the causes are of visual hallucinations in DLB? And if you're starting getting visual hallucinations, what does this mean?
Okay, I think that's a really good question, and it's actually a very difficult question to address. I think one of the sort of early things that people notice is that they notice that I suppose certain medications can cause hallucinations, and I think the obvious ones is people with Parkinson's disease, they go on medications to help with the Parkinson's disease, and as a result of that, then start experiencing hallucinations, and then the medications get reduced a bit and the hallucinations improve. So we do know that some of the dopaminergic medications can really predispose people towards to visual hallucinations. And also we know that some other drugs called anticholinergics can affect people's thinking ability and also cause hallucinations. And so I think medications do have a potential role for perhaps tipping people into a visual hallucinatory state, as it were. But we know that there's something intrinsic as well about having Lewy body dementia, which predisposes you towards hallucinations generally. So perhaps the medications are just giving that little bit of a push into experiencing these phenomena. And we know that the hallucinations can occur early on, even before people start getting memory problems or dementia. And I think the other thing is that we know that, you know, these hallucinations are part of a broader sort of visual symptom problem. People sort of experiencing these illusions and pareidolias, and some people also getting phenomena of what we call presence and passage. And you know, I'm sure some of the listeners who've got relatives who have got or are living with Parkinson's disease will have experienced this, where they might feel as though there's somebody behind them, a feeling of presence, or they might get a passage hallucination, which is these sort of very subtle, fast moving things across their eyes. They often describe like mice running across the ground. And these sort of things can occur before the more obvious complex visual hallucinations. Now, we think a lot of these systems are interlinked, but some of them are separate in terms of what's going on in the brain. And as I say, there's a lot of research going on at the moment to try and unpick these things. And I suppose the view is that a lot of it is how we actually see and interpret the world around us versus our internal world. And we use phrases such as top-down processing and bottom-up processing. So what I mean by bottom-up processing is things coming in from your eye, all the visual information, going to the back of the head, where your sort of visual part of your brain sits, getting processed, getting unpicked, getting sort of re-put together, working out that that's got 4 legs, that's got a top, that's a table. And then top down, what we know about the world, that we know that things with 4 legs and a top, that's probably likely to be a table. And so there's a bit of interaction about where we are of what our brain is sort of knows about the world around us and what signal is coming in. And we think, I suppose, that we are having a situation where perhaps some of the signal coming in is a bit noisy, and then what happens is that the brain is filling in the gaps. So that is in a way quite normal. That's what everybody's brain does. And in actual fact, the brain is an amazing sort of machine in this fashion. You know, a lot of it information we aren't even realizing is getting filled in. We have a bit in our vision called the blind spot, and you don't notice the blind spot, but there is a bit of your vision you don't actually have, but your brain's already filling that in automatically. So it is amazing in that fashion, but it probably just tips into sort of a slightly abnormal state. And you know, a lot of my colleagues are sort of thinking that, you know, maybe, you know, it's better in a way to have, as we call it, a false positive. So better to see what you think is a lion in the bushes than not see the lion, because that's evolutionary to our advantage to sort of get a little bit, oh, is there something there or is there not? So that might be part of the reason why we can experience these phenomena. And if your brain is slightly adjusted, you're more likely to experience these phenomena. And that might come down to different excitability levels in different parts of the brain. It might come down to different connections between the visual part of the brain and the other part of the brain. So this top-down bit. So perhaps we're thinking the top-down bit, the internal world that we have, and is a bit too much, as it were, and it takes over from what is actually the external perception, the bottom-up perception. And that's why the hallucinations manifest. There's probably also chemical imbalances. We know that key chemicals in the brain are altered in Lewy body dementia. I've already mentioned dopamine. If we give a bit too much dopamine, that might cause problems. Acetylcholine seems to be particularly important, and as I'll come on to talk later, acetylcholine is one of those chemicals in the brain we try and boost with the cholinesterase inhibitors. And there's also another system called the serotonergic system. And again, that's probably quite important. And we know that, you know, for example, LSD, which is a drug that people take, and actually that's associated with the serotonergic system that causes people to have very vivid hallucinations. So imbalances in these systems are very important. And probably that's why these are potential targets for when we, you know, drugs that we give now and potential future treatments. So I've probably danced around this sort of, well, what's the causes of hallucinations? I think the bottom line is we've got a couple of different theories and models and things like that, and we're doing a lot of research in this space. But, you know, actually pinning it down specifically still is unclear at the moment, and we need to do a lot more work to really understand that. So lots of ideas at the moment, but no clear conclusions, I'm afraid.
Thank you, John Paul. One question that we get asked quite frequently at the charity is what medications can be used to treat these visual hallucinations?
Yeah, so I think, I mean, and Rachel may speak to the sort of the non-medicine route, the non-pharmacological route, because I think that's also very important. And I think that, you know, there is a lot of medications which we sort of try. I think that, as I've said, cholinesterase inhibitors is probably one of the first line treatments that we use in Lewy body dementia. Now that helps with attention, helps with memory, but also probably helps with visual hallucinations and cognitive fluctuations. So all of those things together. So it seems to be beneficial more broadly. And we know that certainly that the boosting the cholinergic system seems to help some patients. And it's probably the most amount of evidence that we've got is for those drugs. So that's things such as rivastigmine, donepezil, galantamine, which are used in that sense. But that doesn't sort of treat everybody. I think then the other options we've got to think is what else? I think one of the probably sort of taking a step back is we also look at what medications people are taking to begin with. And, you know, as I say, if somebody's on lots of dopaminergic medications to treat their Parkinson's symptoms, we have to think, well, can we reduce some of those a little to actually reduce these hallucinations? Are they on any other medications which might have what we call anticholinergic effect? And we know that some drugs such as tramadol, some of the bladder drugs can really cause big problems. So can we reduce or stop those or substitute something else instead. Then in terms of sort of the other options, I think that we think about things such as Mementine. This is another drug which is used to treat sort of thinking abilities and improving them. We haven't got as much evidence, unfortunately, for Mementine in Lewy body dementia, although we're about to start a trial to really understand, does this medication help? I think the other options then we move into looking at things such as the antipsychotics. Now, the antipsychotics are a drug class that we are quite wary about using in Lewy body dementia, and that's because people with Lewy body dementia can experience really quite marked side effects from those types of medications. It might make them have more Parkinson's symptoms, more slowed in their movements, more prone to falls, more confused, more sedated, and also there's an increased risk of general mortality, if I'm being very honest, with those drugs. And also more broadly an increased risk of stroke as well. So we have to use them with a very high degree of caution. But I have to say, in a subgroup of people, they can be very effective, particularly at low dose. And we can come on to discuss the nuances of what sort of people might benefit from them. But unfortunately, again, the drug trials out there to say what's a great drug, what's the best antipsychotic to use is really not out there at the moment. I mean, I'll talk about some future directions in a minute, and what we might be looking at. So we've got a range of options, but none, we often, and I think as Rachel's just highlighted, each person's an individual. Sometimes we try one thing, doesn't work, we try another thing that might work. Something which might not work at the start might be something we might try later on, and vice versa. So the one thing about Lewy body dementia is that people really do change over time, and each person that comes in is completely different from every other person. So we have to sort of sometimes suck it and see with some of the approaches.
That's great. Thank you very much. Rachel, are there any practical steps and approaches that can be used to deal with visual hallucinations?
So practical steps. This is a thing that families, in that moment when you are looking after somebody or you are experiencing these sensations yourself, you need practical steps. And this is probably as you've indicated, Jackie, people are just looking, aren't they, for how do I manage this? This is very distressing. It's disrupting our daily life, and it's very worrying. The first thing I would say, it's often a little bit like you have to be a bit of a detective. And I think as professionals, sometimes we will be asking questions of families to find out a little bit more about what's happened around the person starting to experience. So as I said previously, the starting point is trying to find out how much insight does somebody have. So if you can still, and often particularly in earlier kind of phases of Lewy body dementia, people do still have quite a lot of insight. So you can often say to people things like, do you think your eyes are playing tricks on you? If the person is aware that they've got this condition, then you can talk about it. It's the condition that's making their brain kind of trick them in a way. But in terms of what to do, I would always, my starting point would be to start making a little note of what's happening. So making a record of when somebody's seeing something, what time of day it is, thinking about what we call triggers. So is there something that's perhaps somebody is seeing that they're misperceiving? And John Paul was talking very much about that, how our brain interprets things and sometimes gets it wrong. And sometimes we find this for people with Lewy body. So a good example is, somebody may see a coat hanging on, the back of a door, and they may look at that and think that's a person. Or it might be a bush that's outside in the garden, may be seen as something that's perhaps an animal or, again, people standing outside. So I think practically thinking through what's the situation it happens, are there any triggers that you can change? So if you're noticing that somebody's always looking in a certain place, have a look and think, is there something that I can change about their environment? Sometimes things like thinking about the time of day can be really important. What seems to happen, and actually this happens a little bit in other types of dementia anyway, is that as the day goes on, people often get more tired. And when we're more tired, our brain perhaps isn't functioning quite so well. And that's when sometimes we see things like the changing of light, particularly this kind of dusk period, when the light's changing, people are perhaps more likely to see things that maybe are not there, but also they're more tired as well. So they're more likely to perhaps get more distressed as a result. So thinking about the lighting can help. So maybe, can you improve the lighting? There was this fashion, wasn't there, that we were all getting all these low light bulbs because they're energy saving. For people with visual problems, this is not great, to be honest with you. So I think, you know, increase the lighting. Think about things like, you know, if somebody is repeating something, actually that's what I was going to say. If something's recurrent, it's probably is likely to be hallucination, because we find hallucinations often have themes. So it will be people see similar things and it happens repeatedly. I would always think about, is there's something else causing it? So again, back to being a detective, what we're always alerted to, is there another possible cause? So delirium is an expression we use, which is cause things like infections, constipation, pain, sometimes thyroid deficiencies. These can lead to what we call a delirium, where people can get very confused, and hallucinations or seeing things that aren't there is also a common feature of delirium. But it's often a little bit different. So people who hallucinate things, it's less likely to be a theme. It's probably a little bit more chaotic and less repetitive. So if you see a sudden change in somebody, particularly hallucination, I would say we have this phrase, we say think delirium. Think about, is there something else that could be causing it? Because if you can get, delirium can be treated. You know, somebody can be given antibiotics, they'd be given perhaps painkillers if they're in a lot of pain. They could have a thyroid deficiency kind of, you know, sorted out. So think about that first. I think the difficult ones that families often talk to me about is when somebody won't be shifted in there. They're seeing something, they're convinced it's there. And as a family member, our instinct, I think, is to try and persuade somebody. It's okay, it's not there, you know, you're seeing things. Now, that can work sometimes if people feel reassured, but sometimes it can have the opposite effect, that people may kind of say, you know, get more distressed. And so a lot of my work when I'm kind of supporting families is trying to think through, what are the things that you can do to respond that will reassure that person? And what we often say is challenging the hallucination isn't always the best approach. Because if that person really thinks it's there and they don't think you're believing them, then you're going to find it harder to support them. So perhaps, you know, just talking, get them to talk about it, ask them more about it. What is it they're seeing? You might actually, through doing that, be able to help them see, oh, actually, maybe it isn't real. If it persists, then sometimes just going along with it may be the best way, and finding a way to distract somebody from it. Now, again, not always possible if somebody's extremely distressed. Sometimes just you're in a room with somebody and they're getting very distressed and they're very frightened, sitting with them, perhaps engaging with a different sense. So for example, if somebody's seeing something, and this is what seems to work with people who have hallucinations with other conditions such as psychosis or schizophrenia, is that getting them to use a different sense sometimes can work. So if somebody's seeing something, using their kind of auditory, so listening to a piece of music, having something that will distract them and use a different sense, sometimes can be reassuring. I think if somebody's at risk or you're very concerned, then you know, safety is clearly very important. So thinking, and actually families sometimes say by somebody else, sometimes they maybe call a neighbour or a family member just to come in to talk to the person. That can kind of break the cycle. It can take that person away from the distress they're experiencing. If you are worried that person is going to harm themselves or you, then obviously call in other services. But I think, as John Paul was saying, is yes, the strategies are really important, but it is this balance between how we respond through what we call psychosocial type approaches, but also thinking about, is there a treatment that may actually reduce some of that distress and take away some of the edge off the hallucination. It may not take them away completely, but in my experience, sometimes particularly things like rivastigmine, if it's effective, can make that hallucination just much more manageable. And people will say things like, well, I still see it, but hey, yeah, it's all right, I don't mind, it's just there, isn't it? I'm sure there's lots more that will come out when we get to our Q&As, but that's probably enough for me for the moment.
Thanks, Rachel. And finally, for this part of the session, John Paul, looking forward, where is research going with visual hallucinations, and will there be any new treatments for this major symptom?
Yeah, again, very good question. I mean, I'll just actually, before moving on to that, just re-emphasize, I think, Rachel's point about delirium. You know, we know that people with Lewy body dementia are very sensitive to developing delirium. So it only requires something very minor, you know, a bit of pain, constipation, you know, a mild urinary tract infection, and that really can tip somebody right across. And, you know, so I think that, you know, if you notice that, you know, somebody is sort of experiencing much more hallucinations, and it's a, you know, real quite sharp change from where they were before, I think then, you know, that should ring the alarm bells. Is there an underlying delirium here which is causing this? And actually then treating the delirium can then, you know, have a positive effect on the sort of the general sort of behavior, mood, and hallucinations. So I think, yeah, I would just want to just underline that that's a really sort of important thing, because it comes back time and time again as one of the main factors. So don't be shy about getting help, calling up the GP and saying, look, I think I can see a change in mum or dad. I need your input on this. So I think it's a very important point. I just wanted to underline. So I suppose looking forward, where's the research going? I mean, I've already, I suppose, hinted at that what people are very interested in is trying to understand the causes of the hallucinations. We're looking at brain scans. We're looking at recording the electrical signals in the brain, really to try and understand the different brain networks which are implicated in hallucinations. We think that some of the attentional networks, those things important for directing your attention, are important. The visual networks, the executive or decision-making networks, the visual memory networks. We think that all these things interlink, and people are studying this very closely. I think one of the challenges in hallucination work is that we have this issue of what we call hallucination trait versus state. So what I mean by trait is that you know that somebody's maybe predisposed to getting hallucinations, but I have to say, when we bring somebody in for a research study, can you actually get them to hallucinate? No, they're absolutely brilliant. They're at their best. So you can never get that state. What is that person experiencing the hallucination, and why? So that is one of the big tricky elements for research for us. And we're trying to really sort of maybe take a look at more natural studies where we study people in their own homes where they are experiencing the hallucinations. I think we're also trying to develop better scales to measure these phenomena. And I think, if we got better scales to measure them, then that helps us then, if we give a drug treatment, does that drug treatment actually make any real world benefit for that person? So that's some of the areas where people are looking at. And then I think the third element is really, can we give anything to actually help with the hallucinations? And I think that, there's a lot of areas which are being investigated. People are looking at the serotonergic system. And again, there was a medication which was used in Parkinson's disease psychosis called pimavaricin. It's a sort of an antipsychotic type drug, but it seems to have a much better side effect profile than some of the more traditional antipsychotics that we give. And it certainly seems to help probably people with DLB and Lewy body dementia. Unfortunately, it's not available in the UK at present, and it's also enormously expensive. But that has shown some benefits, as I say. I think what we're colleagues in UCL, Suzanne Reeves, is looking at a medication called Odanstrotron. Now, some of you may have heard of this. This is actually an anti-sickness medication, but it alters the serotonergic system, and some people have found that it might help hallucinations. So there's a drug trial going on at the moment looking at people with Parkinson's disease and hallucinations, but may extend into Lewy body dementia. We're also, as I say, we're doing a drug trial which is coming up looking at Mementine to try and help with hallucinations amongst other symptoms. And I think the other areas are non-invasive brain stimulation. So this is not sticking electrodes inside the brain, but actually using things such as what we call transcranial magnetic stimulation or direct current stimulation. So far, they haven't been sort of coming up with obvious sort of positive signals, but people are still looking at that. And I think then there's the sort of, as Rachel's highlighted, the practical things, nobody's really taken a look at, changing the lights. Does that help? Removing pattern carpets, distraction techniques. I think we do need to really sort of pin down, do these things help? So we really need to do more research and trials in that. I think, two areas for me, which I think are really important, and again, come back to anecdote, what I've seen, what Rachel's hinted at is that, if people are tired, hallucinations come on more frequently. And I think, again, trying to improve people's sleep can help a lot. So, if somebody's drinking a lot of tea and coffee and is not sleeping through the night, and then they get tired during the daytime, maybe that's a contributor towards hallucinations. Maybe there's some medications which we can use to sort of reset the sort of the body clock, as it were, to help people sleep through the night, which might again help with hallucinations. But again, this is more in the sort of research domain. And also, I think we've talked about eyes being a problem. Some people, as we get older, you experience problems of, getting glaucoma, getting cataracts. We don't fully understand it, but we think maybe that, again, having these eye problems might sort of contribute to, having the hallucinations as well. And there's a bit of work to try and unpick that. But, what I would say practically is that, make sure, you get your eyes tested. If you've got good going cataracts, see somebody, see whether you need to have the cataracts removed. There's a little bit of small amount of data suggesting that maybe removing cataracts might help hallucinations in some people. So I think that's another area. So there's quite a lot. I think. I mean, one of the major things that I've noticed for Lewy body dementia in the past 3 years, and Jackie, you'll probably comment on that from the Lewy Body Society, is that there's a lot more interest in Lewy body dementia overall. There's a lot more interest from the pharma companies looking at new treatments. We never had this interest before, and so people are doing a lot more drug trials, which is really great for the condition, because there's been a real lack of that for many years. So I would be optimistic that in the next few years that we might start to see some better treatments, particularly for hallucinations. So I think that's all I'm going to say. I'm being a little bit vague, but I think that's because the field is still a little bit vague as well.
Thank you, John Paul, for that. I'm sure people found that really useful, and thank you, Rachel. If people are interested in research, we would direct people to our website and to register their interest on Joint Dementia Research to take part. And we do get contacted by individual researchers from a wide range of institutions across the UK where they've got specific projects, and not necessarily ones that we are funding, but if we get contacted where they're looking for people to participate, please keep checking out our website, because we will post details of these really encouraging projects on our website. So moving on to questions from our participants, we've got a number of questions in the Q&A box, which I'll now start to go through, and we'll answer as many as we can. So the first one is, I would like to ask about a reoccurring delusion hallucinations with my dad. Firstly, he believes my 13-year-old son is dead, which is very difficult and distressing for us both. And he has this memory that he was in a car accident. Any advice would be appreciated. Who would like to take that one first?
You want to, shall I give it a go?
Yeah,
Go on, Rachel.
You go, Rachel. I mean, I think, I'm sure Rachel will comment. This may be a sort of combined pharmacological and non-pharmacological approach. But Rachel, I'll let you go first.
Yeah. So I think it's back to what I was saying before about looking at how much distress this is causing for somebody. And I think what John Paul touched on it before about, for some people, hallucinations can get very strongly linked into what we call delusions, so this false belief. And it sounds like this might be the case, Suzanne, with your dad. So I think checking out how fixed is this? You know, is there any way that at points that he can see that it might not be true? So finding out, is there an opening, and is there any ways or tips that you can give him that help him think to check it out with somebody? So if he's worried, and I didn't mention, but we have just developed our new leaflet, which is based on tips that both people with who've experienced hallucinations, but also family carers, about what might help them. And certainly for people who've got a bit of insight, helping them develop strategies. Any strategy you have to practice, and people might need help with practicing them. But, you know, giving him if he starts to think this, is there a cue? Is there something that he can do that will kind of shift him away from thinking that a little bit? I think if it is really causing, and that does sound very distressing, that I think also talking to the, you know, whether it be the neurologist or the psychiatrist or the GP about, is there something that can does he need his medication reviewed? So that, is there something that's making it worse that can be changed? Or as John Paul said before, about trying a new medication. I don't know if you have something you wanted to add, John Paul?
Yeah, I mean, I think this sort of highlights a very important point of that, you know, it is like the brain gets railroaded into particular states, as it were. And again, this is an area of research. So, you know, recurring themes seem to be very common, whether that's seeing something or seeing something plus having I suppose, a delusional story around that. And when you get that combination, it can be particularly troublesome and problematic, and if you've got a lack of insight into that. And I think that, you know, this is why sort of a pharmacological and non-pharmacological approach is probably best here. The pharmacological side of things might help just, I suppose, reduce down that sort of the degree of how fixed idea is in someone's head. And, you know, again, you know, looking at what medications are there that we might actually try and reduce or stop, versus then what needs to be introduced or changed potentially. And, you know, when certainly from my own clinical practice, when there is this very marked delusional intensity to things, that's where some of the antipsychotics can be helpful. And, you know, we use things such as quetiapine is one of the drugs that we use. And another one which some people use, particularly the neurologists in very sort of selected people, is another one called clozapine. It's not so much used in this country, but it's used in the US a lot. And so, you know, these things may help just shift things. Cholinesterase inhibitors also have their in place as well, but maybe when there's sort of those delusions, the antipsychotics are slightly better, but need to be used, as I said before, with a very high degree of caution. But when we have these sort of practical conversations with, you know, people with, you know, living with Lewy body dementia and their families, it's all also about quality of life. So, you know, it's balancing up. Maybe there might be a little bit of increased risk of being on this drug, but if my quality of life is better, then that's often, you know, something that people would go for, because, you know, this does sound incredibly distressing for the gentleman in question.
Thank you. Moving on, another question. My husband was originally diagnosed with Parkinson's. He only developed hallucinations after being prescribed with Madapur and then Sinemet. These were reduced somewhat since the introduction of rivastigmine and Mementine. Are they likely to return again, as they were very distressing at one point?
Again, very good question. I think, first of all, we all can hallucinate under the right circumstances. That's, you know, that's nature of humankind, as it were. I suppose what we have is we have a line here, you or I, it may be actually a very high threshold before you might hallucinate. So you've got to be really quite unwell, very marked delirium. But if you've got Lewy body dementia, threshold is lower. If you've got Parkinson's, it's also lower. Now, when you give some medications which are pro-hallucinatory or cause hallucinations potentially, then you're much more likely to hit that line much earlier on. And then we have medications which bring things down a bit. So it's about the positioning of that line. So what I would say is that, you know, there is a potential that they may reoccur. Sometimes I have to say a lot of people actually, when you've got the medications optimized, they don't necessarily occur or don't occur to the same severity. So, you know, we may look at, you know, in certain circumstances about, you know, altering the Matapar dose, the timing of the doses, or the Cinemet doses. And then, you know, with the combination of the rivastigmine and Mementine may also help control things. But, you know, I think, again, coming back to that point of delirium, you know, if the hallucinations suddenly re-emerged, then that would sort of ring the bell for me. Well, is there something else which is triggering this? Is it something like delirium? I mean, Rachel, I don't know if you wanted to add anything to that particular question.
I think you've covered it really, JP. I think, as you say, I mean, again, as you said earlier on, actually, people do change, don't they, quite a lot. And so I have found sometimes medication's been tried and it hasn't been effective. And then later on, it can be reintroduced. And I think, you know, our instinct is that, oh no, that's been tried. I don't want to try it again. But often, if it isn't going to cause any harm, then I think sometimes it's worth giving it a go. I haven't come across loads of people where rivastigmine, something like rivastigmine, has been beneficial in reducing hallucinations. In my experience, haven't found that they've recurred later. But sometimes, I guess that's sometimes to do with the nature of this condition, that it can progress a little bit quicker than other conditions. And that might be just worth bearing in mind, that sometimes people do deteriorate, and as awareness and cognition deteriorates, perhaps people's responses may reduce as well.
And again, what we've sometimes seen is people earlier on in the condition are given a cholinesterase inhibitor. They find that that's too activating. They feel a bit agitated, and then it's right. Oh wait, we can't try that again. But in actual fact, as things perhaps progress a little bit and how the brain changes, maybe the rivastigmine being reintroduced might actually be beneficial. I mean, there's, you know, with caution, of course, I think, but sometimes we just have to be aware that the condition is evolving and changing over time. So sometimes, you know, it's a bit of a black art, it has to be said, managing the medications. But you know, I think being willing to adapt is important.
Thank you. Next question. How do you explain what is happening to the brain, to the person living with Lewy body dementia and the families, especially when they have such different experiences? The person living with Lewy body dementia really believes that the visual hallucinations, and we've just touched on this a little bit, are real, while the family members recognise they are hallucinations. So I think we've covered a little bit of that, but have you got anything to add, Rachel?
Yeah, I mean, I think, yeah, how you kind of have talked about it. I guess sometimes I think it's very hard as families to adjust the way that we communicate with each other. Because, as I said, our instinct is to want to kind of bring that person back to our reality. If we see somebody changing, or they're hallucinating, or they're thinking something is real that isn't, our instinct is we don't want that to happen. So we want to kind of bring people back to what we see as our reality. And as I said before, sometimes that doesn't always help. So it's difficult, I think, to ask. I often kind of practice with families about, when this happens, what can you try? And then trying out different responses and seeing which one seems to work best. So it might be just accepting that's what the person is experiencing, and not disagreeing with it might be the best thing. It might be just sitting with them whilst if they're experiencing something distressing, and saying, you know, I know you can see that and it must be upsetting, but I'm here, it's okay. Distracting them using something like a relaxation or music, or, as I was saying before, using a different sense. But yeah, I think one of the biggest adjustments is for families is about trying to accept this is something that perhaps we can't change. I don't know if that answers.
Yeah. I'll mute Jackie. The famous unmute.
The famous unmute. John Paul, again, we've touched on this, but I don't know whether you've got anything to add to this question. What's the best medical intervention for aggressive hallucinations, like murdering and seeing dead bodies?
Yeah, and I mean, I have seen people who have experienced these things, and again, you sort of ask about, sometimes there is a background history, perhaps they were involved in a war or something like that. Often the case is there's no association there, so where is this coming from? And it can be incredibly graphic and incredibly distressing for people experiencing these things. And I think, as I say, that's where perhaps if it's a sort of very strong fixed ideas, maybe the antipsychotic medications might help some people. I think the other thing that we have sort of noticed as well is when these very negative hallucinations is sometimes exploring with people what their mood is, what they're feeling, because we know that depression is very common in Lewy body dementia, and it doesn't necessarily manifest in a, oh, I feel sad. It may manifest in other ways, physical symptoms, agitation, anxiety, and sometimes actually managing that sort of depression anxiety element actually might have a sort of a knock-on benefit in terms of sort of the content of the hallucinations. Now sometimes that's just some degree of reassurance through to then actual antidepressant medication, but that's something also we consider. Rachel, I don't know if you wanted to add anything to this one.
No, just that it's incredibly distressing, isn't it, if somebody's experiencing something like this. Yeah, I don't think I've got anything to add, really, John Paul. You've covered it, really.
I mean, I will come away with a relatively, I suppose, positive message that with the right tinkering, to use the word, of interventions, we can often get to a place where people are not experiencing quite the degree of these sort of severe hallucinations. I have to say, what we don't tend to do very well is get rid of hallucinations completely, but we often get to a state where hallucinations are manageable, that they're only intermittent or they're not distressing. So I think what I would say is, if there is if you're getting these problems, then really speaking to your GP, speaking to your specialist, and looking at what ways there are to manage this. And of course, if there's a high degree of sort of concerns and risks, then clearly that, as Rachel's highlighted, you need to get seeking more immediate help for this. And I think if this is also a new phenomena, then think, is there something going on which is triggering this, such as delirium?
Okay, thank you. I'm conscious of time. I'll try to combine a couple of the questions. So a couple of questions from Kirsty. If and again, we've touched a little bit on this. If somebody's having hallucinations frequently, every day, and they're becoming more frightening to the person, they've tried to reduce, they've increased medication, things have got worse, it hasn't reduced the hallucinations, and generally just getting more frightened, what would you advise?
JP, I don't know if you want to answer the thing about typing, because it can be variable, can't it, in different people?
Yeah, and again, I mean, this comes back to why we need to do more research studies, because quetiapine is one of the few antipsychotics we tend to reach for, and that's mainly because it's got a slightly better side effect profile than some of the other antipsychotics, which we know can cause very serious side effects in people with Lewy body dementia. But unfortunately, the evidence of saying does quetiapine actually work is a little bit hazy, for want of a better word. And I think that does make it sort of challenging if the quetiapine is not necessarily working. Do you carry on increasing it? That's one option, but that doesn't help everybody. Do you try another agent? I think this is where really specialist input is really required. And, sometimes it might even require a very close monitoring, if you wanted to try a different antipsychotic. Clozapine has been used in some people, but again, that requires blood tests, and lots of people can get side effects from that medication. And I have to say, I always go back to it. Is there anything that we can, first do no harm? Is there anything that we need to be looking at that person's taking already, which needs to be altered or changed? Is the cholinesterase inhibitor, has that been optimized? Have we tried Mementine? Have we tried anything else before we start, thinking about alternative antipsychotics? Because I have to say, there is real challenges. I've had some people who have been put on risperidone and it's worked wonderfully, but other people have been put up on risperidone and they've ended up in hospital. And when Ian McKeith did the first studies with Lewy body dementia, the reason why he thought there seems to be this different type of dementia is because he was seeing people on the wards coming into hospital. They were given antipsychotic medication, and he would go back, and they weren't there. They had died. And that's as a consequence of antipsychotics, and that's how he thought. Well, there must be this different type of dementia. So we have to be very, very cautious, as that's to be said. And I don't have any right answers. It's often coming down to the individual of how you manage that individual. So what might be the answer for one wouldn't be the answer for another, which does make Lewy body dementia challenging to treat.
Yeah, I mean, just to add to that, Jackie, I think when somebody is so distressed and something's so frightening and medications are being tried at home and they're not either making things worse or are not helping, it's not ideal, but sometimes an inpatient admission might be what's needed just so that things can be tried in a safe place and be monitored. I know inpatient admissions aren't necessarily what people might want, but sometimes it might be the best way. So for example, something trying like clozapine, that often is that needs to be monitored very carefully. So that was the only thing I would be adding to that. But it might be, and it depends who's involved in the treatment. I often find that GPs need a bit of a nudge to make a referral back to psychiatry or to neurology to review things. As John Paul was saying, this overview of what other medications, what other things are happening that may be making things worse is really important.
And sometimes, just add to that point that Rachel's made, is I think that day hospitals also have their place. That's sort of intermediate to going into the hospital, but allows that sort of close monitoring. I know we've had a few people come through our day hospital being put on clozapine that way, so that can work as well. Depends on the local setup.
Okay, so one final question. We'll try to combine a few things. The difference between hallucinations and delusions, and the different types of hallucinations like visual, auditory. Do they all come at the same time? Can they come at different periods of somebody's diagnosis?
Yeah, so again, very good question. So I suppose the first thing to say is that delusions are about having beliefs about things, and you can have delusions without hallucinations. So, that's, and often we associate delusions as part of, for example, schizophrenia. So it's really those firm beliefs which you cannot alter or change. You cannot persuade the person otherwise. And these are sort of variants with the real world, whereas hallucinations is experiencing something in a sensory domain which isn't there. So you might have visual hallucinations, so seeing something that's not there, or you might have auditory hallucinations, for example, hearing something which is not there. Now, in Lewy body dementia, the predominant hallucination type is visual, but we do know that hallucinations occur in other domains or modalities. And these things can, again, there's a bit of research looking at this. Sometimes they are sort of isolated, so somebody might have a hallucination of seeing something or someone, but they might also then have an auditory hallucination of hearing a bell, so they're not necessarily associated. Other people, we call them multimodal. They're coming together, so the person might actually see the figure of a man and hear his voice speaking, and that sort of often tends to be those sort of multimodal ones who are much more distressing. Again, Rachel might want to comment on that. So they can come and go. I have to say that the tendency, if a person's getting multimodal hallucinations, that tends to be sort of the fixed, it sort of occurs right the way through. Whereas if you're getting hallucinations in just one modality, then it sort of tends to be, that again remains sort of the same the whole way through the condition. But I have to say, I've just said that now, and I'm sure I'm going to see somebody, this week who'll probably sort of dispel that notion that I have, and it comes back to we just don't know quite enough. But I would say hallucinations in other modalities and sensory domains are more common than we think, and probably are associated with more distress.
Yeah, I was just going to add to that point, because I was just looking at the question, Jackie, where that came from, and I think there's just an important point about sleep and when these experiences happen. So when somebody has what we refer to as REM, sleep behaviour disturbance, or a disturbance where somebody has a nightmare and they're woken up, or they may not wake up themselves, but it may be that they're kind of crying out and families hear them, is that I think in my experience, these seem to be more multimodal, actually, interestingly, that people have these kind of different things going on for them. Sometimes it is back to this thing about trying to unpick what's causing, what's the trigger, what might be making things worse or better. And sometimes actually the sleep disturbance in itself, I think John Paul earlier on was talking about using, you know, various strategies, and it might include medication at some point, but trying to get that sleep cycle balance, because if somebody's sleep cycle is disturbed and they've been woken up, is it the hallucinations waking them up, or is it the sleep? Are they just waking up and then experiencing something because their brain's trying to work out what's happening? We often don't really know, but I think it's sometimes actually treating the sleep disturbance can help with managing some of the other symptoms.
Yeah, that's a really important point. I have to say, REM sleep behavior disorder can give rise to, you know, people having very vivid phenomena, which then come as they come awake and they're very confused. And we call them honoroid states, and multimodal, very vivid. I have to say, positively, we've got a lot of treatments which can actually help with REM sleep. So if it's sleep which is very much strongly associated with these phenomena, you know, go and see the specialist, talk about potential interventions. Because you know that we do have good effective treatments for REM sleep behavior problems.
Okay, thank you very much, John Paul and Rachel, for what I'm sure everybody on the call will agree today has been a fantastic session. If anybody hasn't seen our leaflet, please visit our website and you can download it, or you can email us and request hard copies. It's a really, really interesting leaflet, which I'm sure everybody will agree. So thank you again, everybody, for joining us. Thank you. Bye.
Thank you, everyone. Bye-bye.
Bye.